Okay, gang, so there are actually a really good mixture of questions, and so I think we will get almost everyone's opinion on this. So thank you very much for your questions. I think one of the other things that is really amazing about kind of these very patient-oriented conferences where you can actually see people that live and breathe neuroendocrine in person is that you also have lunch and stuff like that. So if we don't answer the depth of the question that you have, it's all of us are here. And you can just either ask during lunch or say, hey, you didn't, I had a very specific question. I think that one of the things about these conferences where it's just sort of the disclaimer is that what hasn't been brought up, I think, in the intro was that you could have one thing that is seemingly exactly the same as the neighbor sitting in the waiting room, and yet you'll be like, wait a second, their discussion about what we were going to do is different, and that's because no case is really all exactly the same, and that's why it's really important to know what the unique features are of your case that are driving the medical decisions, and that's the beauty of multidisciplinary neuroendocrine programs. So I have a number of different categories because I had the opportunity to put these into categories, and so I will just go like eeny, meeny, miny, moe. So let's just start with the surgery ones. So there are a couple that are just general surgery problems, and then there's one about the medical decision making. So one that you're going to start by answering just the one that says how you commented on how you would follow. I actually had you to two. Comment on why you would follow something that is 2 centimeters or whatever because of a risk of something going up, whereas if it were to be more than that, you would go with surgery. And I think that's logically you'd say, well, why would you wait? Why are you doing it? And then 2, if you then decide to operate on someone, there are a couple of questions about hernia risk.
So I think that we always want to weigh when we do something as surgeons, well, as physicians in general, the risk of what we do versus the risk of what we're doing it against, right? So is the tumor that we're seeing at risk for spreading and taking your life versus is the operation designed to remove it at higher risk for significantly injuring you or taking your life, right? And so if it's a small thing on your skin, yeah, cut it off. Why not, right? Easy. If it's removing half of your pancreas, where you have a real risk of death associated with it, that balance changes a little bit, right? So we're trying to pick people that are going to derive the most amount of benefit from the operation that we're offering. Because I know Mary knows this too, but as surgeons, you never want to hurt anybody, and it's a horrible feeling when you do something to somebody when you're trying to help them and you end up making them worse. Right? Or even that they die because of it. So I think those are the things that go into that metric. And so we know that there are certain patient populations that these small tumors are not going to be a problem. Like I mentioned before the advent of CAT scans, people were dying with these all the time and they never knew it and it was fine, they lived their lives. And we're finding out the same thing with a lot of different cancers. Prostate cancer, one of those things. Like most men over the age of 70 are probably going to have some early prostate cancer, but it's probably not going to bother them. So I think it's that trying to pick a solution that is not going to be a risk to you versus what the risk of the tumor is.
Hernia.
Oh, hernia, yeah, well. So I think, hernia, anytime we make an incision in the abdomen, there's a risk for developing a hernia. The bigger the incision, the bigger the risk. So if you have to have an open operation, then that risk of hernia goes up. Especially around cancer surgery when you're going to potentially be malnourished going into it, if you're going to be getting chemotherapy after it, if you are going to have trouble with your blood sugars, which impairs healing. All of these things increase that risk of getting a hernia. So open cancer surgery has probably the highest hernia risk of any surgery that we do, and so unfortunately it does happen. Those hernias, when they do develop, can range from something that's just unsightly and never going to harm you to something that causes pain or can cause bowel obstructions and needs to get fixed.
Yeah, and on that note, because since Dr. Rose sits on some of the guideline things, is that guidelines are based on evidence. And so when we say that we would watch something, it's because the risk associated with something is actually greater than the benefit. And so we are almost obligated to at least follow to a certain extent the guidelines. And then if you're going to go off guidelines because you're going to take something out, then we are going to describe to you why we would do that. But the one thing that's really important that he didn't discuss in his thing but is related to hernia is that if you were to look at the types of cases that are done in the pancreas, and you have a tumor that is in a location of the pancreas for which minimally invasive techniques are appropriate, that if you go to an old timer like me or my partner that is not nearly as well versed in robotic techniques, it is really inappropriate in neuroendocrine for us to do an open operation when really we have shifted uniformly to less invasive, techniques. But that hernia is one of those reasons why you would have to say, wait a second, and that's why surgery is really good to get a second opinion, is that we would do that. So he didn't bring it up in his thing, but it actually is kind of really important when you're going neuroendocrine, because if you go to a surgeon that just really adeno, we don't do as much of the robotic stuff because we worry about margin status. But with neuroendocrine, if it is an important part of the pancreas, really the standard of care now in the guidelines would be that if it's not being done robotically, you'd almost be having them have to explain why. Would you agree with that?
Yeah, I agree. I think minimally invasive surgery, especially for left-sided lesions, there's a clear benefit in doing this with the robot or laparoscopic. I think for Whipples, the data's a little bit mixed. I mean, I've done robotic Whipples. I'm not a fan of robotic Whipples. Yeah, personal opinion is it's a dumb operation, but there's many reasons for that. But I do think that one of those things that has shown benefit is, one, you get back to work quicker, and you have less risk for hernia long term. Okay, Dr. Del Rivera, a histamine question. So, do you have any suggestions for itching associated with high levels of histamine, and are there studies addressing high level histamines, like what damage that would be, similar to how you discussed serotonin?
Right, yes. Histamine is hormone. It can also be produced. We have seen it more with lung neuroendocrines than other neuroendocrines. That rarely happen, but when it happens, it can certainly produce the symptoms related to like rashes, itches, the skin being quite itchy. And in those situations, there is a drug called ranitidine, which basically blocks the histamine production too. There is another drug is called Montelukast, which is also an antihistamine as well. So those are the medications. Sometimes that can help as well to help control some of the symptoms related to the excess of histamine. I think, what is the second part of the question? Are there any ways to, is there any data on downstream side effects or organ-based side effects of high histamine levels over time? No, not necessarily, not like the excess serotonin. That's a good question. So, I mean, certainly excess of serotonin, as we discussed, it can have other, long-term complications. We discussed, it can affect the heart, it can cause mesenteric fibrosis that we discussed, but we have not seen it as much for histamine. That said, the symptoms related to histamine excess, we know it can be quite debilitating as well, because having the feeling of being itchy all the time is not something that is comfortable for a lot of patients. So not necessarily an organ effect, but more about the symptoms that can be quite debilitating as well.
Okay. May I ask a follow-up question?
Of course.
How often have you seen it in your practice, the histamine release?
I have seen it in lung nets more than other neuroendocrine tumors. I have not very often, I have to say. I have seen it maybe in the last year. I have seen it in 2 patients. Okay. Yeah.
Okay, I have 2 questions for you that I think may be coming from the same table. So when we are imaging people and we're trying to interpret the images in the context of a biopsy-proven diagnosis, so we've got apparently, according to the card, a pancreatic neuroendocrine diagnosis, but a cyst on the liver. And so when you are looking and interpreting cysts on the liver, are they related to the pancreatic neuroendocrine? Can they be related? And I suppose, how would you know whether or not they were related?
Okay. So liver cysts are not uncommon. They are benign and they can happen. We find them incidentally on scans a lot of times. And the way we would differentiate, for example, if you had, let's say, a CT scan to start off with, if it is a well-formed triple-phase CT scan of your liver, or MRI, will perform MRI of the liver with either EOS or hand to the two dyes that we use. The radiologist can say the degree of confidence if they think those lesions are actually cystic or liver cysts. So that's how we rely on our radiologists to look at those lesions and tell us what the level of suspicion is. If there is any question about whether that particular lesion is not a cyst versus a solid tumor or lesion that has spread from the pancreas, a rotated scan can also be helpful. But most of the times, if you have a good radiologist who's kind of helping you with that decision making or guiding you that this is, they can confidently call it a cyst. But they're looking at certain features of how the contrast is being absorbed and released that helps us differentiate between those lesions.
Yeah, I was just going to add, so some neuroendocrine tumors can appear cystic, meaning fluid filled on imaging, but usually they're going to have a rim around them that's a little bit thicker than the normal liver or the pancreas or whatever it's in. And I tell my patients it's kind of like the Tootsie Roll Pops, where you have the candy shell and then the gooey center. So these things aren't really filled with fluid like a water balloon is, and that's what a normal cyst is. It's just kind of a water balloon in an organ. These are usually what we think is that a tumor that maybe has grown so fast or has some other genetic component in it that's making the center part not be able to live. And so the living tumor is on the edge, and there's usually kind of a dead goo in the center, and that's what we're seeing as a cyst. And so they do look different than the water-filled ones that were kind of normal, benign, non-cancerous cysts. So we can usually tell the way that they look.
Okay, I will answer a couple of the histotripsy questions. One of them is, could histotripsy be a viable option for pancreatic neuroendocrine in a tricky location? And are there any studies being done with histotripsy being used in the small intestine primary or mesentery? So the answer to both of those is not currently. There is a trial out of Spain that is using histotripsy in the pancreas. The safety data has now coming out in published form, so it is going to pass safety, but you have to go from safety to effectiveness, and so we aren't yet even in the effectiveness. Personally, I think that we have tried a lot of ablative techniques for the pancreas, and they've been complicated with pancreatitis and a lot of complications that haven't been worth it. So I am hopeful, but only cautiously optimistic, it's going to be that much different with histotripsy, but it's clearly on the horizon. It is just not even in clinical trials in the U.S. And then on the base of the mesentery, I have an entire talk on histotripsy in the base of the mesentery. I think it's going to be a complete and utter game changer now that I've treated people with histotripsy. It will come out in clinical trials, and then I think big programs, neuroendocrine programs that have strong surgical things, is that we will be able to likely make that clinical trial then available, but they need to then make us a probe that we would be able to then place laparoscopically, fill the belly up with water, and then move certain things out of the way. All things that I think are very reasonable, but once again, I got to get safety data in the pancreas, because safety data in the pancreas will ultimately translate into safety data in the base of the mesentery, and then ultimately we'll have to come to clinical trials. So I doubt that will happen probably within the next year, but I would say that it will definitely happen in my professional lifetime. So probably maybe a year or two as the emerging data on histotripsy becomes much stronger.
Yeah, and I just like to comment on histotripsy because there's a lot of stuff online. This technology is being very heavily and aggressively promoted by the startup company. And I think that it is a great technology. I'm very excited about it. We don't have it yet at UAB. They crunched the numbers and said it's just not, for some financial reasons, we weren't going to buy it. But I think that there is going to be some use for it. I think it's a great tool. I think it's an ablative technology, just like microwave and radio frequency and IRE. It's going to have its uses. I'm very cautious. I think experimentally it makes sense that you turn it into the goo, the body's immune system can sample that, and it can have some effect somewhere else in the body. I do not think that there is good evidence for that, so I am very skeptical of anybody claiming that yet. It'd be great if it pans out, but I don't think we're there yet. And then I think that the base of the mesentery thing is a very interesting idea. I think there's some really cool things we can do it in the liver because it can preserve blood vessels and bile ducts and things like that. It's all very cool. The data behind that technology is not as robust as the other ablative technologies we have. We've got decades worth of radio frequency and microwave ablation. So if you're going to do something to one lesion, we have great data for 2 technologies, and we have a year's worth in very small trial data on this new technology.
Right.
I do think it's very cool. I'd be very skeptical about what you read online.
And if I can make just one quick comment, is that, because
This
I
is
have...
the NIH, this is, the principal just showed up.
Yeah. So one thing that I just want to mention, because I always get this question from patients, is like, but is FDA approved? Like, why, if FDA approved as a device, we still don't know what it's going to do on each specific tumor type. And that's kind of a clarification that I would like to make. Like Dr. Rose said, we still don't know what will be the full efficacy in neuroendocrine tumors. We still need to generate that information, so we don't know. If that makes sense.
Yeah, absolutely. And I think, the Hope for Liver trial, which is the one that allowed us, got the FDA approval, it was a mixed bag of tumors. It wasn't just neuroendocrine, it wasn't just pancreas, it was a renal cell and colorectal, and I think there's a couple.
Well, Hope for Liver was actually only primary.
It was only primary, okay.
Hope for Liver was only primary liver cancer, which doesn't relate to any of you, but it relates to people that have unique vulnerabilities because they often have cirrhosis and things like that.
Yeah.
So, and it was a positive trial. So yes, it's a FDA-approved device, and yes, it is approved effectiveness, but it's approved effectiveness in honestly one
Right.
tumor type.
Right,
And
right.
that's the trial that they used. And now it is being obviously used widely in different tumor types, where, yes, I think we are going to agree with the whole panelists, is that the neuroendocrine community is very active on social media. And so before we have part of the neuroendocrine community completely like pushing it all down, like saying unequivocally it's all hearsay, and then some of the neuroendocrine community can also be very active saying, oh my God, it's the nirvana, or whatever, is that we need the neuroendocrine community to come up with our own thing. And I think for the most part, we're all like normal, reasonable people. And so the outliers that are pushing it strongly in neuroendocrine are probably a small voice, and the reasonable people are all like, hold the phone. I just don't want people to get their hopes up. I definitely don't want people paying out of pocket for something, and that's happening. I've had people that have gone to GoFundMe. I was like, are you kidding me? Like, you are not going to do that when I can get something approved through your insurance with decades of data. And so
Yeah, exactly. And it's getting extrapolated, and I think there's because of some financial pressures with this that small hospitals got sold on this thing. They have to hit a certain number per year to get their reimbursements, and so they're pushing it on things that I don't think are indicated. I had one patient who had over 10 pancreatic adenocarcinoma metastases and was convinced some patient to get one of them chipped off at a time at $25,000 out of pocket per pop. This is a person who's probably going to live for 9 months, and he's using his entire life savings to get these little things burned, melted out of his liver. Completely inappropriate. So I'd just be very cautious about what you read online.
yeah, and then if you want opinions, there absolutely are opinions out there in neuroendocrine that we can do. And so I'm optimistic, but I think that we need to be reasonable. Okay, back to you, Dr. Rose. The largest tumor you've ever seen in the pancreas. You brought up calcification. How do you test for that? And are blood transfusions common with pancreatic surgeries?
Okay, so let's see. Biggest tumor. What was the transplantation? Was the next question?
No, was calcifications, because you brought it up. Blood transfusions, when are they necessary? And the largest tumor that you've ever seen. One of you did have a big picture of a big tumor.
Yeah, that was a big liver tumor. So in the pancreas, is the pancreas primary? Probably, I don't know, 15, 16 centimeters or so of a neuroendocrine tumor. I mean, I just took out one the other day that was 25 or 30 centimeters, but that's a different type of tumor. And calcifications, they're pretty rare, maybe 5% or so of pancreatic neuroendocrine tumors, but they seem like on this more recent study that they're a higher risk feature. So in those people that are in that 1 to 2 centimeter gray zone of what should we do, should we offer an operation, should we watch it, it might push us a little bit more towards removing it in a young, healthy person. But again, it's one of these things you have to look at the patient as a whole picture. If I get a 42-year-old coming in with a 1.6 centimeter calcified solid tumor, we're going to be talking about removing it because I think the chances it's going to get to 2 centimeters in their lifetime is pretty high. If it's an 85-year-old, we're not doing anything, right? Even if they're a healthy 85-year-old. And then blood transfusion, I try to avoid blood transfusions as much as possible. There's some very spotty and old data that giving blood transfusions in the setting of cancer increases your risk of cancer recurrence. The thought was that it weakens your immune system because you're giving somebody else's cells to the person, and that maybe that's inhibiting the immune system and letting the cancer grow faster. So the data's not great there, but I just try to avoid it if I can. So I will let people get down to very low blood levels before transfusing them for cancer.
Okay, Dr. Gupta. So there are two. I'm trying to get like a two first. Okay, so can a non-functional tumor ever change to functional and vice versa? And is somatostatin receptor analog therapy for functional tumors or non-functional tumors equally?
So first question, can a non-functional tumor turn functional? I have not personally seen that happen. If you are diagnosed with you will know at diagnosis if you have a functional tumor in most cases. So if you have carcinoid syndrome at diagnosis, you're going to have carcinoid syndrome. If you have already metastatic disease, meaning distant organ spread, and you do not have carcinoid syndrome, the chances of you having carcinoid syndrome in the future are extremely low. I have not personally seen it. I don't know if Dr. Rivera has seen it. You can ask her, but that has not happened to me. The second question about
Somatostatin receptor analogs.
Yes. So somatostatin receptor analogs, lanreotide or octreotide, definitely different for functional versus non-functional, because in functional, you're using them for symptom control as well as for controlling tumor growth. In the non-functional setting, the primary goal is to help with controlling tumor growth. So those are the major differences. For functional, even if you have had some progression in terms of your cancer getting or your tumor getting worse, you continue the somatostatin analog to keep the symptoms under control, right? In the non-functional setting, there is varied opinion on this, on when to stop it, if it's no longer working and actually controlling the tumor.
Can I?
Absolutely.
Yeah. So yes, I mean, I think a couple of situations here about, if they're non-functional, they become functional. I think that neuroendocrine tumors of the small bowel, when it's localized, when it's in the small bowel, they're usually non-functional. When they go to the liver, metastasize the liver, that's when they start producing hormones. So it's possible that maybe you were initially diagnosed with a small bowel neuroendocrine tumors, maybe there was no follow-up, and then you have tumors in the liver. That's when they become symptomatic, and then you have the excess of hormones. That would be one scenario. The other scenario is, for example, when in pancreas neuroendocrine tumors, like I said, most of the times they're not functional, but sometimes over time, the cells start to change a little bit, and then they start becoming secrete other type of hormones, and we call that paraneoplastic. And in those situations, the hormones that has been produced, for example, is the one that produces the excess of cortisol. So we have pancreas neuroendocrine tumors that can produce, or thyroid neuroendocrine tumors that over time they can produce, the cells change a little bit and they produce a very specific hormone. But again, usually the symptoms are very specific related to the hormone excess. But that's when the situations where I have seen that they're non-functional and then they become functional.
Okay, I learned that because I haven't seen it, but I
Yeah.
can totally see how that would happen.
Yeah.
Okay, so back to you then. We didn't actually talk about like KI staining and things like that. So the KI 67 staining, is it now considered a standard by pathology departments compared to 10 years ago? And then on the same card is going to be a marker question, pancreastatin, the value of pancreastatin, and is it becoming more widely used outside of our specialty medical practices?
Mm-hmm. Okay, so I can comment and anybody else can add. So the first question was about the KS67, whether that's standard. As you have heard earlier, KS67 is the proliferation index. It tells me how the cells are able to be divided under the microscope. Based on the parameters, then we can say whether the neuroendocrine tumor is low grade intermediate grade, or high grade based on the numbers of what the pathologists may see. Usually it's a pathology report, so that's why having a good pathologist that can read the pathology report, and sometimes we need to have second opinions as well within the pathologist, because it's important that you have a good pathologist that can read that, because that's kind of like the pathologist is the one that reports the number, or how much is the Ki-67. And it is a marker of prognosis. That's what we know about the Ki-67. It's a marker as well that tells me whether the tumor is low grade or high grade, and that's the standard for neuroendocrine tumors of the GI and the pancreas, as well as lungs. Maybe not as much, need more validation for other neuroendocrine tumors, such as pheochromocytomas and paragangliomas or other tumors. But yes, it's a marker that tells me whether the tumor is low grade or high grade, and it tells me as well over time how the patients may do. The other question was about pancreastatin. So pancreastatin is like chromogranin, but this doesn't have the drug effect. Like, for example, chromogranin A, like even earlier got a question about chromogranin A, like, do we need to check chromogranin A? Usually the recommendation is that we don't check chromogranin A, because that can also be falsely elevated by other factors, like, for example, the anti-acid medicines can certainly increase the chromogranin A by a lot. There are certain foods, whether it was on fasting or non fasting at the time of the day. So there's many factors that can affect the level of chromogranin. So that's the reason why usually we don't follow chromogranin. It's a marker of neuroendocrine, but we don't follow in order to understand disease biology and neuroendocrine tumor. Pancreastatin doesn't have that effect in terms of being affected by other medications, but at the same time, I don't think there is enough information to really help us determine whether there could be a prognostic factor. I mean, there hasn't been studies about the use of pancreastatin, but it's not something that I personally use, and I usually follow, in terms of determining disease biology, I usually follow the scans, and that's kind of like where it helps me determine as well, disease growth as well as the Ki-67, but not necessarily chromogranin A or pancreastatin, unless anybody else uses pancreastatin.
No, I don't use it either, and I think there is also a test called neurokinin, and so amongst all these tests, I think it's important to understand how these tests are going to actually help us make treatment decisions. One of the things we get taught in our medical training is order a test if it's going to help you. Are you going to act on a test that you're going to order, right? So if that test is not adding value or changing the way we're going to offer treatment, then that test, some tests are for research purposes, and that's fine. But unless we have more information on how to use that test, it may not be appropriate to use it in standard practice.
Yeah, and one thing about Ki-67, I think in 2025, if you're getting a biopsy and your path report comes back and doesn't have a Ki-67 on it, and they're still doing mitoses, go somewhere else.
Yeah.
Like that.
Or you have to have it reread.
Yeah, you gotta have it reread, right? That just tells me the pathologist does not see NETs very often. So I'm not sure that I believe their staging.
And it will happen in community-based things. And so even though the AGCC it is part of the standard, I think that depending on where I get that, and you go for bowel obstruction and you get it, and they say, oh yes, this is consistent with a well-differentiated neuroendocrine tumor, and that's it.
Yeah.
And it is. Well, then we do then have to track it down, and then we have to have it reread. That's an extra expense to you, and most of us within neuroendocrine are like, couldn't you just read it? Okay, so I'll answer one other question, and then we're going to break for lunch, and then I think some of the PRT questions we can just wait after Dr. Charan has done his case. So then he asked whether or not any of the things that I discussed, including the PRT, the stripsy ablation or whatever, are ever used in metastatic neck or immediate and high-grade tumors. And the answer to that is actually going to be very patient-specific, because I'm going to say that I use it not infrequently, but I use it complementary. So if I'm saying that something is complementary, I'm going to use it in the context of not burning any bridges on my ability to use systemic therapy or targeted therapies. I'm going to do it knowing that I can get an objective response rate that's probably higher than systemic therapies in that location, but I'm going to set expectations much lower on the value of that longer term or the durability of that response. The beauty of it is that none of the treatments that we discuss are mutually exclusive, But on the flip side, you can't be using something like aggressive radioembolization and shooting a bunch of radiation into a liver in a well-differentiated tumor when there are PRRT options where that really hasn't been well studied on the additional toxicity of PRRT, directed to the somatostatin receptor avidity in the liver as well. So I have definitely been creative. That's when I get into my creative. I have been very creative at using complementary. It's usually going to be liver-directed therapy plus systemic therapy, or liver-directed therapy to divert PRRT, so that your hungry hippo, the liver is not just the hungry hippo for all of your PRRT dose. We have cytoreduced in the liver in order to then get the PRRT to more distribute to the bone or the extrahepatic disease where we don't have as good targeted treatments. That is where I do believe that if you have a really complicated case and multi-organ system involvement that sounds actually a lot worse than it actually is in well-differentiated variants, but that is where the neuroendocrine subspecialty centers are superior to some of the even cancer centers, like an MD Anderson type thing that tends to be very focused on systemic therapies. Is I think we are much more willing to accept the complementary nature of what it is. I don't know how you guys do that at a UAB.
Yeah, I think I agree. So I think for even people with NECs, the poorly differentiated tumors, there can be role for local therapies like liver-directed therapies, very rarely surgery. But I think that that spectrum of how a patient behaves can be very different. The numbers you get from a doctor when you ask them how long do I have to live and kind of thing, those are averages, right? And so within that group of people, there are going to be people who don't do very well, but then there's going to be some people who actually do pretty well, right? And we used to put all these grade 3 tumors into one bucket and call them all bad, but we realized about 5 years ago that actually there's a group of them that do okay. And now that created this whole new category of well-differentiated grade 3 tumors. And so I think you just have to be very selective on your patient, and you tailor it to your patient, and big net centers are going to understand that probably better than other places and help design a program that's right for you and not a average patient.
Yeah, and I will say, Dr. Rose and I have had a patient with grade 3 neuroendocrine tumor who got systemic therapy, got some liver-directed therapy, eventually went to surgery, and does not have any evidence of disease now, right? So they have been on this journey for almost 2 years, and now they have no evidence of disease. Whereas there are other patients who need to remain on systemic treatment, their biology is more aggressive, right? And the same for neuroendocrine carcinoma, which can be even more aggressive. So far in my practice, I've had one patient who got chemotherapy radiation for gastroesophageal neuroendocrine carcinoma, did really well for almost 2 years and had no significant evidence of distant progression, but started to have symptoms locally. And they did end up going to surgery and have been doing well for over 6 months. So there are rare situations when definitely surgery and local options are appropriate, but it really depends on the biology of your disease.
Great. Okay, so now it's about time for lunch. If I were to just point out, because Dr. Del Rivera was really good at actually going over some of the symptoms that people have and then some of the drugs that are available. So you've got people here that are, part of those companies. So the Zermello, the Tilostat, the Dr. Del Rivera. So if you're having intestinal manifestations of carcinoid syndrome and you want to talk to the Zermello guy, he's like right back there. The oral medication of a somatostatin receptor analog that's making its way through. It was a very good, positive phase 2 trial, effectiveness trial. It's moving into phase 3. And so people that have flushing as some component of their carcinoid syndrome, there is going to be a phase 3 trial available in there. You can talk to, that's the Crinetics guy, that's the paltusotine trial. And then the raised bio here is when we're talking about PRT later, and you can look into the context of those two, sitting back there. After Aman Chauhan's talk is that you have the alpha particle data that's coming down the pike, and how do we make decisions on what types of particles that we're going to use in the future, but the raised biopeople or the actinium-225. So that's now in a phase 3, which is really the will it become a standard of care trial, and then obviously the Novartis people with Lutathera, it is the standard beta. They are also have a really neat phase 3 that's likely going to be available in your back door using beta particle PRT early in the course of the disease. So for all the people with specific questions maybe about sort of PRT and some of the oral medications, those are these guys sitting in the periphery. Okay, now's lunchtime.
Thank you.
How do we have?